I'll click on OK, right? I'll just double check to see whether people on Zoom can hear me and see the slides.
We can hear you and we can see it.
Great, thank you so much. Hi everyone, I'm Lingyun. Thank you so much, Dave, for having me here. So as Dave mentioned, this is a hard to pronounce word. I actually practiced it a few times. Design of randomized non-inferiority trials. How do I proceed? Okay. So recently, Dr. Todd Alonso and I had a paper published in Clinical Trials. In that paper, we evaluated use of non-inferiority tested proportions in design of randomized non-inferiority trials. We focused on trials with time to event endpoint and with low event rate setting. Today, I will present some findings from that paper. This is the outline of my presentation. We will first talk about non-inferiority trials. We will discuss why non-inferiority trials are important in pediatric cancer research and describe the challenges in the design of those trials. Then we will discuss non-inferiority designs based on tested proportions. We will introduce sample size formula, compare sample size requirements between tested proportions versus proportional hazards analysis, like a logrank test. And then we discuss when we could use tested proportions in design of non-inferiority trials and some other considerations. So superiority trials, they represent the majority of randomized controlled trials. They test whether the experimental arm is superior to the standard arm with respect to some clinically relevant outcome. Although some new treatments offer greater efficacy, there would be treatments that may be marginally less efficacious, but may have better safety profile or are easier to administer or are less expensive. And these treatments can be tested with non-inferiority trials. For non-inferiority trials, the magnitude of the effect of the standard therapy is well known, and a non-inferiority trial assesses an experimental arm that's less expensive or easier to administer or has fewer side effects compared to the standard treatment. So the aim is to demonstrate that the new therapy retains most, if not all, of the clinical benefit of the standard treatment and is not meaningfully inferior. In statistical terms, this is formalized by establishing that the experimental treatment is no worse than the standard treatment by more than a specific non-inferiority margin. And this margin is defined as the acceptable amount for which the experimental therapy may be worse than the standard therapy, but still be non-inferior. So non-inferiority trials place a limit that the experimental agent can be worse than the standard treatment. They test a one-sided null hypothesis that the standard arm is more effective than the experimental arm by the pre-specified margin. For trials with time to event endpoint, non-inferiority margin is often expressed as a hazard ratio for experimental agent versus standard of care. So it needs to be larger than 1. The null hypothesis is that this hazard ratio is no less than the hazard ratio margin. Non-inferiority trials often power at an alternative hypothesis that the hazard ratio is 1, meaning the two arms actually have equal efficacy. This is a figure showing possible outcome scenarios in non-inferiority trials. This is in Mueller et al. 2012, but a similar figure can be found in many other papers. So if we have time to event endpoint with data from non-inferiority trials, we can estimate the hazard ratio of the new novel treatment versus the standard treatment, and we build a confidence interval of the hazard ratio. We compare the confidence interval to the pre-specified non-inferiority margin. On the x-axis, the blue dotted line, the delta is the pre-specified non-inferiority margin on the log scale. So scenario B if we compare the confidence interval of the hazard ratio to the pre-specified margin, we can see that the confidence interval excludes the margin and lies below the margin. So with this scenario, we can claim non-inferiority of the experimental agent. Similarly, we can claim non-inferiority in scenario A. In fact, in scenario A, because the upper bound of confidence interval lies below hazard ratio of 1, we actually can also claim superiority. In scenario C, the confidence interval of the hazard ratio does not exclude the pre-specified margin, so we cannot claim non-inferiority. In the last scenario, the lower bound of the confidence interval actually lies above the pre-specified hazard ratio margin, so the new treatment is actually inferior. Maury and co-authors in 2017 conducted a review, and they noted that the number of randomized controlled trials assessing non-inferiority has increased significantly. They reported that in 2005, just under 100 trials were listed in Medline under the general rubric of non-inferiority. However, in 2015, there were almost 600 such trials, and these trials span multiple medical and surgical disciplines and diverse treatment strategies. Richelman et al. 2013 conducted a systematic review of non-inferiority clinical trials published in PubMed and ASCO, and they focused on cancer clinical trials, randomized phase 3 cancer clinical trials. They focused on adult cancer. They searched in publications published between the 10 years of 21 to 2010. They found 75 eligible articles that met their inclusion criteria. Using those 75 articles, they described the scope and purposes of non-inferiority trials. So the majority of those trials were actually published after 2007. Some of those trials were conducted in supportive care setting. Most of the trials were conducted to evaluate treatment for various cancers. The primary endpoint used includes time to event endpoints such as overall survival, progression-free survival, disease-free survival. Also, some trials used binary endpoints such as response. The majority of the trials actually reported positive results, but some reported negative results. With those 75 trials, the authors described the purposes of non-inferiority trials. They reported that 29% of the trials evaluated a treatment that has convenient schedule. 12% evaluated a treatment that's both convenient to administer and also has less side effects. Another 23% evaluated treatments that are less toxic. 15% of the trials evaluated treatment that has less dose intensity. And for 2 trials, the treatment involved has a smaller number of drugs. And for 2 trials, the treatment is less expensive. Unfortunately, 13 trials failed to report the purpose of their studies. The authors also described the distribution of the pre-specified non-inferiority margin. For time to event endpoint, the median hazard ratio margin is around 1.3 with a range of approximately 1.1 to 1.5. For binary endpoints, the margin is generally between 10 to 15%. Hashim et al. 2021 conducted a more recent systematic review of non-inferiority trials. They also focused on adult randomized clinical trials. They searched in PubMed, and as of 2019, there were a total of 285 publications that met their inclusion criteria. The majority of those trials were published after 2010, and there is clearly an increase in the number of non-inferiority trials in the recent years. Most of the trials were phase 3. The authors also looked at the distribution of non-inferiority margins in hazard ratios, and it's generally between 1.1 to 2. They also looked at the relationship between the margins and the required sample size. So as the margins decrease, there is an increasing trend in required sample size.
Sorry, quick question. Are these, in that plot you just showed, are these the pre-specified?
Yeah,
versions?
pre-specified, yes.
So did they say how they chose them? Is it arbitrary?
They should, based on the guideline from consolidated standards in reporting clinical trials, something like that. We need to specify or explain how we specify the non-inferiority margins.
But is there like a cost benefit that goes into defining?
Oh, yeah,
that, right?
definitely. Yeah, it is.
Because it's a ratio, the hazard ratio, right? Limit.
Yeah.
So what goes into that cost benefit usually?
I will discuss some of that aspect in the later slides, but generally, the non-inferiority margin cannot be more than the effect that we observe using the standard of care. So you cannot just study a treatment that goes back to the history, basically. Non-inferiority trials are also very important in pediatric cancer research. Many pediatric cancers have high survival rates with existing treatments, but these treatments often come with severe high side effects. Even with modern treatments, there are kids diagnosed with cancer who died of treatment. So non-inferiority trials allow researchers to test new treatments that may be less toxic. Also, for children undergoing cancer treatment, quality of life is a major concern, and non-inferiority trials help identify treatments that are less burdensome or invasive without compromising effectiveness. By doing that, they improve the child's experience during treatment. Also, cancer treatments tend to have long-term side effects influencing kids' growth, cognitive functions, neural functions in the long term. So there is the need to de-intensify therapy for patients with exceptionally good outcomes to reduce chronic and late toxicities. Reeds and her colleagues 2023 presented outcomes of pediatric patients with acute lymphoblastic leukemia based on COG experience. They also described the treatment strategies for kids with ALL. So as we can see, over the decades, there is a steady improvement in outcomes of patients with ALL. Back in 1950s, ALL was a fatal disease, and patients died with ALL tend to die immediately after or shortly after diagnosis. In 1960s, investigators found that cytotoxic agents can induce remission, and that way they improved the outcomes of the patients significantly. Then in 1970s, investigators looked at combination of cytotoxic agents and prolonged treatment durations, as well as aiding central nervous system prophylaxis, including CNS radiation. By doing that, there is a huge jump in outcomes of patients treated, diagnosed with ALL. After that, there have been a series of randomized clinical trials studying different combinations of agents or new agents or different treatment schedules. And then the outcomes of the patients are actually getting better and better over the years. In 2010 to 2015, the majority of the kids diagnosed with ALL are actually cured. And based on most recent experience from COG trials, these outcomes are actually further improved. In a figure, we show the average outcomes of all the patients diagnosed with ALL. And one can imagine there would be subgroups of patients with favorable genetic features who will have better outcomes than shown in the curves. So Rates et al. Commented that as high cure rates are achieved for pediatric patients with favorable risk features, efforts are underway internationally to investigate reduction in cytotoxic therapy to reduce toxicities or late effects while preserving outstanding outcomes. And this would be the case with many other pediatric cancers with good outcomes. This is an example non-inferiority randomized phase 3 trial reported by Lingyun and her colleagues, or his colleagues. In this study, they evaluated treosulfan plus fludarabine as conditioning treatment in comparison to the standard of care of busulfan plus fludarabine. This conditioning treatment will be given to patients before they receive transplant. The patients that they studied are older patients with acute myeloid leukemia or myelodysplastic syndrome. In introduction, they wrote that when combined with fludarabine, treosulfan showed a particularly favorable acute organ toxicity profile. Also, rapid and sustained donor cell engraftment was observed with treosulfan. So in this study, they clearly are studying a regimen with reduced toxicities. In statistical analysis, they described their assumption regarding the EFS rates assumed for the standard care treatment, and also their assumption regarding accrual rate. Also, they specified their non-inferiority margin of 1.3 in hazard ratio. With those assumptions, they calculated a sample size of 930 patients that will provide 80% power to exclude any relevant increased risks of events with treosulfan compared to the standard care busulfan. Although they planned to enroll 930 patients, they actually didn't enroll that many. The study has 2 planned interim analysis, and at the time they performed the second interim analysis, the objective of demonstrating non-inferiority of treosulfan was actually achieved. So the Data Safety Monitoring Committee, or DSMC, recommended termination of the trial. Using the patients randomized prior to the second interim analysis, the study team compared the outcomes of the 2 treatment arms, the experimental arm treosulfan and the busulfan standard treatment arm. They built a confidence interval for the hazard ratio of treosulfan group versus the busulfan group and compared the confidence interval to the pre-specified hazard ratio margin of 1.3. Because the confidence interval lies below the hazard ratio margin, the study demonstrated non-inferiority of the experimental arm treosulfan. These figures present the difference in EFS, OS, cumulative incidence of relapse, and treatment-related mortality rates between the experimental arm treosulfan, which is the blue curve, versus the standard care treatment for standard care arm, which is busulfan. So we can see that the treosulfan group has a significantly better EFS than OS. They also looked at cumulative incidence of relapses and noted that the 2 arms are actually pretty similar. However, the treosulfan group lead to significantly less treatment-related deaths. So they looked at the deaths in the busulfan group. They noticed that many of those patients suffered from chronic graft versus host disease, the GVHDs. And patients with GVHDs are actually those who had infections after they received busulfan. So treosulfan significantly decreased infections that would further lead to GVHDs that would lead to deaths after patients receive transplant. Hence, because the treosulfan significantly reduced the toxic deaths, that lead to better EFS and OS of the treosulfan group. So this trial successfully demonstrated that treosulfan should be used to replace the standard of care. This is another trial that also studied conditioning therapy before transplant. They compared combination chemotherapy as conditioning treatment strategy versus total body irradiation in patients with childhood ALL. They wrote that TBI, total body irradiation before transplant in pediatric patients with ALL is efficacious but can have long-term side effects. So their study was designed to investigate whether preparative combination chemotherapy is non-inferior to TBI. They planned to enroll 1,000 patients, but apparently they stopped in the middle due to the same reason as the last trial, because they performed planned interim analysis and the futility boundary was crossed. So at the time they performed the futility monitoring, results showed that combination chemotherapy arm had significantly worse overall survival compared to TBI group. Hence, the DSMC or Data Safety Monitoring Committee recommended closure of the study. So TBI, despite being toxic in the long term, the study team continued to recommend TBI as the standard of care for patients who receive transplant, at least in this patient population. So we can see that non-inferiority trials are becoming more common, but there are challenges in the design of these trials. In non-inferiority trials, the target treatment effect generally is smaller than in superiority trials. Larger sample sizes generally are required to achieve the necessary level of evidence. The increase in sample size can be quite dramatic. Rossman proposed to use a non-inferiority margin of about half of the superiority margin associated with the benefit of the standard therapy. So this partly answers the question just now. So if we choose the non-inferiority margin to be half of the superiority margin, that means a non-inferiority phase 3 trial could require roughly 4 times the sample size of a similar standard superiority trial. And the large required sample size often makes non-inferiority designs infeasible because of the inability to complete the study in a reasonable time frame. We also noted that the sample size can be even larger in low event rate setting. Let's look at the second row over here, where the 3-year EFS rate in the standard care treatment arm is 98.6%. So it's really, really good. This is a low event setting. If we do a non-inferiority trial with a margin of 1.5, then if we want to have a trial that can complete enrollment within 5 years, which is still a long time, 5 years, that would require a total sample size of more than 9,000, meaning an annual accrual rate more than 1,800, and that's almost impossible for any pediatric cancer. In fact, for ALL, there are more than 1,800 patients newly diagnosed every year. However, when we do clinical trials, we often do risk classification. So randomization is often performed within a subset of patients diagnosed with the cancer. So that way, we will never, I feel like in pediatric cancer, it's almost so hard to achieve annual accrual rate of 1,800 patients per year. So that motivates our paper. In our paper, in the context of a randomized non-inferiority trial in cancers with low incidence, low event rates, and a time to event endpoint, we evaluate a design based on a non-inferiority tested proportions. We compare sample size requirements between logrank test versus the tested proportions in a non-inferiority setting. We assess whether there are scenarios for which a non-inferiority tested proportions can have reduced sample size and can be more efficient. We provide guidelines in use of this test method. When we have time to event data, if we want to compare survival curves between 2 randomized arms, the most commonly used analysis approach would be a logrank test. Alternatively, we can choose a landmark time of interest and then compare the proportion of survival between the 2 randomized arms. That way, we reduce the analysis of time to event data to a test of 2 proportions. In this paper, in our paper, we evaluate whether use of a tested proportion can reduce required sample size in non-inferiority setting.
Excuse me for just a second. If you have the log-rank statistic and there's no censoring at all, you know, you follow everyone to extinction. Well, I guess there's an administrative standpoint. You know, but your 5-year period. Are those tests equivalent? Log-rank and the test?
I think they are still not equivalent.
Okay.
Oh, the they probably tend to be equivalent in superiority testing, but in non-inferiority testing, I don't think they are.
Okay.
That's my intuition. So this is the notation for non-inferiority logrank test. So we assume two-arm randomized control trial with the standard therapy arm as the control arm. Let T be a non-negative random variable representing the time between randomization and the failure event of interest for patients randomized. Lambda 1 and lambda 2 are the hazard functions for the control arm and the experimental arm. Delta is the hazard ratio with the standard arm as the reference group, and delta 0 is the non-inferiority margin, which is larger than 1. These are the hypotheses. If we reject the null hypothesis, we conclude non-inferiority. N is the sample size, N1 and N2 are the sample sizes for the two arms. Q1, Q2, they are the proportion of patients randomized to the two arms. So if it's equal randomization, Q1 and Q2 will be equal to 50%. Alpha is the type 1 error. For non-inferiority trials, we often power at a specific alternative hypothesis that the hazard ratio is equal to 1, meaning the two arms have the same efficacy. So based on John et al. 2005, for non-inferiority logrank test, this would be the number of events required for a non-inferiority trial. And we need to convert the number of events to sample size N because not every patient will have an event of interest. In our paper, transforming the number of events to the sample size N follows Locato's method. We assume the time periods are in unit of years. 100 equal intervals were used within a year to correspond to a non-stationary Markov process, one for each treatment group. And event rates and loss to follow-up rates were specified for each of the intervals. The primary analysis will be based on construction of one-sided confidence interval for the hazard ratio. This is a notation for tested proportions. Again, two-arm study. P1, P2, they are the proportion of patients event-free at the selected landmark time in the two arms. The landmark time of interest that we chose was 3 years. So we are going to compare 3-year EFS rates between the two arms. Delta 0 is the non-inferiority margin. These are the hypotheses. Again, if we reject the null hypothesis, we conclude non-inferiority. The primary analysis will be based on a one-sided z-test. This is the test statistic and the variance. Because we have time to event data, we propose that P1, P2 can be estimated based on Kaplan-Meier methods. Also, the variances can be based on Greenwood standard errors.
Sorry, the delta naught is pre-specified, that's that.
Yes,
And again,
pre-specified.
same sort of way of pre-specifying it.
Yeah,
Yeah, okay.
yes. Based on Chow et al. 2008, this would be the sample size required for non-inferiority tested proportions. When loss to follow-up rate is not 0, we inflated the sample size to account for patients who are lost before the landmark time of interest. For example, if the loss to follow-up rate is 5% per year, that would mean within 3 years, 14.3% of the patients would be lost to follow-up. Then we inflate the total sample size by this factor. We consider the Q. This Q.
Oh,
Oh, the Q is the proportion of the patient randomized to the arms. Thank you. We considered a wide range of scenarios. We set alpha at one-sided 5%, beta at 20%. We assumed the staggered accrual, and the trial is assumed to enroll for 5 years, randomizing in a 1-to-1 ratio, and we assumed 3 additional years of follow-up. For the loss to follow-up rate, we assumed 0% up to 15% per year. This would correspond to up to 40% loss to follow-up rate within 3 years. So losing 40% of patients is very unusual in cancer research, especially in pediatric cancer research. In fact, recently, investigators at COG, they looked at the loss to follow-up rates in COG phase 3 trials and reported that 3-year loss to follow-up rate is around 4.5%. So 2% per year loss to follow-up rate would represent the most commonly scenario in pediatric trials. For survival distributions, we assumed that they follow Weibull distribution with the two parameters, lambda and gamma. And this is the values that we choose. This is the figure that demonstrates some of the scenarios that we considered in the comparisons. The top row represents the low event rate settings. And then the medium row represents the moderate event rate settings. And the bottom row represents the high event rate settings. So our comparisons really covered a very wide range of scenarios. For non-inferiority hazard ratio margin, we assumed it's 1.25 up to 3. But based on the literature review, 2.5 or 3 would be very large hazard ratio margins. However, in low event rate settings, 2.5 or 3, they actually correspond to a drop of 3-year EFS rates of 1%, 2%, or 3%. So we think they are still relevant. We included them in our comparisons. When we do tested proportions, we matched non-inferiority margins so that the two test methods are comparable. To do that, for each lambda, gamma, and delta 0, we calculated the corresponding 3-year EFS rates for the two arms. And then we take the difference of the 3-year EFS rates between the two arms, and that is used as the non-inferiority margin for tested proportions. Let's look at 1.2 scenario as an example. This is a low event rate setting. The 3-year EFS rate in the control arm is 98.6%. If we use 1.5 as the hazard ratio margin, then we calculate the 3-year EFS rate in the experimental arm at the null hypothesis. That will give us 97.9%. And then we take the difference of these two 3-year EFS rates. The difference is negative 0.0068, which is 0.68% in drop of EFS rate, 3-year EFS rate. And that difference is used as the non-inferiority margin for tested proportions. That way, we matched the scenarios for the two test methods, making them comparable. So these are our results. We first focus on loss to follow-up rate of 0%, meaning no patients are lost to follow-up. In this figure, we have hazard ratio margins of 1.25 up to 2.5. Let's first look at hazard ratio of 1.25. There are two figures here on the left. On the y-axis, we present the ratio of the sample size for tested proportions relative to log-rank test. So if the ratio is below 1, the yellow line, that means tested proportions reduce the sample size compared to log-rank test. But if the ratio is above 1, that means log-rank test has actually smaller sample size. And the x-axis on the left figure is the Weibull shape parameter, which is the gamma parameter. Each of the lines in different colors, they represent a choice of lambda. So when hazard ratio margin is small, there are still some scenarios where tested proportions can lead to smaller sample size. And when we look at the right figure presents exactly the same results, except that on the x-axis, we have control arms 3-year EFS rate. So we can see that the scenarios that have benefited from tested proportions, they usually are low event rate setting with the control arm EFS rates being above 80%. So if we increase the hazard ratio margin, we can see that more and more scenarios would benefit from use of tested proportions. And if the hazard ratio margin is 1.75, the majority of the trials would benefit from using tested proportions. And sometimes the decrease in sample size is actually dramatic. Again, the majority of these trials would represent low event rate settings. And also, when the gamma parameter is small, the reducing sample size is often bigger. Another finding is when lambda is small, often we can benefit from use of tested proportions compared to log-rank test. If the hazard ratio margin is further increased, the magnitude of the benefit by using tested proportions is getting bigger and bigger. And in fact, if we have a hazard ratio margin of 2.5, almost all the trials would be better to be designed with tested proportions. This table presents the same results, except that they give more detailed scenarios. Let's look at scenario 1.2 here. The control arm EFS rate is 98.6% at 3 years. If we use the hazard ratio margin of 1.5, that leads to 97.9% 3-year EFS rate in the experimental arm. Then the hazard ratio margin, the non-inferiority margin for tested proportions will be 0.68%, less than 1% basically. And if a trial requires 5 years of enrollment by using logrank tested proportions can reduce that sample size and reduce the enrollment duration by a little over 1 year. If the hazard ratio margin is 2, then tested proportions can reduce the duration of enrollment by more than 2 years. So we can see that in this low event rate settings, in the majority of the scenarios, we can benefit by using tested proportions in design of non-inferiority trials. If the 3-year EFS rates in the standard arm drops to 87%, there's still benefit of using tested proportions in design of non-inferiority trials. However, if the 3-year EFS rate in the control arm continue to drop to 74% as shown in this scenario, there's no benefit using tested proportions any longer. Here are scenarios where the 3-year EFS rates in the control arm are below 50%. These would be high event rate settings. There is no benefit of using tested proportions any longer. Now we look at the loss to follow-up rate of 2% per year, which is 5.9% in the first 3 years. Just now we mentioned that this probably would cover the majority of pediatric cancer research. We can see that the figures are small, but the patterns are pretty similar to what we observed just now with no loss to follow-up. If the loss to follow-up rate increased to 5%, we can see that the benefit of using tested proportions starts to become smaller, but in some scenarios, there is still benefit using tested proportions. And then if loss to follow-up rate increased to 10%, again, the same pattern, the magnitude of the benefit shrinks, but there are still scenarios where you could benefit from using tested proportions, especially the hazard ratio, if the hazard ratio margin is large. But if the loss to follow-up rate increases to 15%, which means approximately 40% of the patients will be lost within 3 years, then generally there's not much benefit using tested proportions any longer. But losing 40% of patients in 3 years would be very rare. So these are our conclusions. A non-inferiority tested proportions can have significantly reduced the sample size when the long-term survival rates exceed 88%, or when gamma is small, or when lambda is small, or when the hazard ratio margin is large. For example, if long-term survival rates are more than 80%, if gamma is less than 0.5, or if the hazard ratio margin is more than 1.5, the majority of the trials designed based on tested proportions actually have smaller sample size than if we design using logrank test. The benefit of using the tested proportions was observed even with a considerable loss to follow-up rate. So for cancers with low incidence rate and low event rate, where a non-inferiority trial based on logrank test is not feasible, use of non-inferiority tested proportions can make such a trial feasible. Let me look at the time. I think I still have some time. So we also tried to understand why tested proportions would have increased the power than logrank test in non-inferiority testing, but not in superiority testing. So we looked at the asymptotic power of proportional hazards analysis or logrank test versus tested proportions. And we compared the power and non-centrality parameters between the non-inferiority testing versus the superiority testing. To make things comparable, we assumed that the event rates of the control arm, which is the standard of care arm, for non-inferiority testing are the same as the event rates of the experimental arm in the superiority testing. Also, we assumed non-inferiority margin is the same as the superiority margin. That way, we make the scenarios comparable between non-inferiority testing versus superiority testing. So here we present the power of the two analysis methods, and this table presents the non-centrality parameters of the two methods for the two testing settings. We first looked at a low event rate setting. So in this figure, we assumed the lambda take a value of 0.01. So this would represent the low event rate setting where the 3-year EFS rate is probably 98% or 97% around there. We plotted the non-centrality parameter against the hazard ratio margin. On the left side, that's the non-inferiority testing. The red curve is the non-centrality parameter for tested proportions, and the blue curve is the non-centrality parameter for logrank test. And we can see that when the hazard ratio margin is above 1.2, the non-centrality parameter for tested proportions is always above the blue curve, leading to bigger power of non-inferiority testing of proportions. However, that is not observed in the superiority testing because the blue curve on the right side is always on top of the red curve. So logrank tests always have better power than test of proportions in superiority testing. We also looked at a moderate event rate setting. In this setting, the lambda parameter is set at 0.1. And then in this moderate event setting, we can see that the non-centrality parameter for test of proportions in the non-inferiority testing is only above the blue curve when hazard ratio margin is large. So that explains why the benefit of using test of proportions only exists for large hazard ratio margins if the event rates are large, for moderate event rate setting, or for large event rate setting. For superiority testing, the logrank test has better power than tested proportions. So there's no benefit using tested proportions in superiority testing at all.
Is that true even when proportional hazards doesn't really help? In other words, when your shape parameter for the libel is not equal to 0.
That's a good point. We actually, in our paper, we didn't really evaluate the violation of proportional hazards. The reason was I have seldom seen violation of proportional hazard assumptions in pediatric cancer research. Also,
But your models include this.
yeah, true. Right, we just didn't evaluate, if we adapt some of the parameters, if the proportional hazards assumption is significantly violated, how the change in the power would how this would change the power. So what we thought was, if the separation of the curves, if they separate in the beginning, but then gradually they come together, so that would be a violation of proportional hazards. But in that case, logrank test lose some power, but still probably can capture the early separation. And the tested proportions will definitely lose opportunity of capturing the difference in the two curves. However, would we care about that difference? Because the early difference doesn't translate into long-term difference. So we probably don't care that much about that early difference. That's why I didn't worry too much about violation of proportional hazards. Another way would be, what if there is no separation in the beginning, but there is separation later on? Well, tested proportions can capture that.
Yeah.
Yeah. So so that was our considerations. Regarding choice of non-inferiority margin, so defining appropriate non-inferiority margins is important for non-inferiority trials. Bertling et al. 2021, they commented that in practice, the targeted non-inferiority hazard ratio margin is frequently set with the baseline rates in mind. In a low event rate setting, this is typically done by considering the margin as a difference in survival rates at a fixed time point. Note that in many low event rate settings, such as adjuvant cancer therapy, differences in the long-term survival rates represent by far the most relevant summary measure of clinical benefit as they reflect the difference in cure rates. This is very interesting because even when we design non-inferiority trials using logrank test, this would be how we select the non-inferiority margin for the hazard ratio margin. But this is exactly how we should select the margins for test of proportions. So I find that to be very interesting. Rossman, oh, sorry, lost that page, proposed to use a non-inferiority margin of about half the superiority margin associated with the benefit of the standard therapy. We noted that when the EFS rates in the standard treatment arm are very high, meaning in a low event rate setting, a large hazard ratio margin can translate into a small drop of only 1% or 2% or 3% in EFS rates. Large non-inferiority margins may be applicable to rare oncology settings, but their use would really need to be justified with careful and thorough evaluations and discussions among investigators. We also discussed the use of parametric models, which can potentially lead to power gains compared to non-parametric estimations of proportion of survival at a landmark time. Also, we briefly discussed how we could potentially adjust for confounders. Interested readers can look at this paper, which gave a very nice review. I gave the references cited in this slides over here. That's my presentation. Thank you so much.
Sorry, before I ask other questions, I have one that just, okay, and you touched upon it in this last part. And I'm glad you got to that because it seems like the right way to interpret this in terms of coming back to choosing the threshold, the delta naught or the right is on the scale of proportions, right? But I guess maybe my first question is has anybody done any work where it's not in a testing framework, but in an estimation framework where there's error around that specification? Because if you think about it, depending upon like the frequency of these events and the trade-offs, go back to the trade-offs of these and choosing that margin, you would want to incorporate that, right? And so in your tests that you outlined when you made your comparison at the end of the chi-squared non-centrality parameters, you had a point estimate for each one of them, but there's really uncertainty around that.
Yeah.
And so you're asking the question about sort of comparing to a distributional point that could be very narrow, given the frequency or the outcomes or the toxicity of whatever these things are, versus something that's very large if it's, other things. And so it seems more natural that you might want to ask the question of, well, what's the probability that it's larger?
Yeah.
What the difference is given all sorts of the distribution of that. Does that
Yeah, that makes sense. So the choice of the non-inferiority margins, they really need to be carefully, determined. Usually when we do a non-inferiority trial, the standard of care is well known and well established, well studied. So we should have pretty precise estimate of the effect of the standard of care. But again, there's still some error in estimation. Some investigators propose to build a confidence interval of the effect of the standard of care and use the lower 95% confidence interval as the hazard ratio margin for the non-inferiority test. And then after you conduct a non-inferiority test, you build the confidence interval, 95% confidence interval again. You will compare the upper bound of the 95% confidence interval to the hazard ratio margin. So that's called something like 95% testing or something like that, because they involve two confidence intervals.
But it's not so much that the standard of care has a precise estimate on the scale of survival, let's say. It's that the standard of care and the new treatment have benefits, costs and benefits on some other scale, like toxicity. You're weighing, do we have a benefit in toxicity
Right.
versus a cost in deaths?
Yeah.
Right?
Yeah.
And that has uncertainty around that, right? And
Yes.
so in the example you gave earlier, you know, it was sort of deaths from toxicity versus deaths from disease, right? You're balancing those two, but it's kind of hard to quantify toxicity when it's not death,
Yeah.
right? Something like that, right?
True, yeah, yes, so that's why determination of the margin really needs to be determined on the clinical ground, and it needs to be discussed with investigators. Every cancer is probably different. We did a literature review, actually a review of the COG clinical trials. Some of our non-inferiority trials, they used larger non-inferiority margins. I think part of the reasons were the treatment was really toxic with the standard of care, then you could risk larger decrease in EFS rates by reducing the severe side effects.
Especially if it's in the realm of being large survival probabilities for all of them, right?
Right,
You know,
right.
it's worth taking that risk.
Yes,
So,
yes.
any other questions in the room?
Another question, how do you pick the time at which you do the test proportions?
The time, so the 3 years apparently a random pick. For COG trials, usually after the completion of the enrollment, we would want to follow patients for at least 2 or 3 years, and 3 years is a commonly used time that we often use. For many cancers, the survival curves, they tend to plateau out after a certain period of time. 3 years would be the plateau time for some, or at least a subset of the cancers. After that, there would be events, but not too many. Yeah. Sorry. Go
I
ahead.
was actually accused of scientific misconduct for not using the logrank test, for using a test for the EFS. We published the paper in the New England Journal.
Oh, that's interesting. Yeah. I guess it probably depends, like in the scenario where there is early separation of survival curves, but then they go together after a period of time, like, the first year they separated a lot, but then 1 year later they come
When we
together.
published the paper, we only had the data up to about 3 years. There were still patients that had less follow-up than that. And 3 years was.
I guess if you,
For a study like what you're talking about, which, accrued patients for 4 years, this means no longer than. But and the reason why we chose the EFS was because we thought there'd be some treatment related toxicity. The treatment was bone marrow transplant. And we have some really difference. Even if you have their overall outcomes.
I remember there was a trial that we encountered. So the curves are separated in the beginning, but 2 or 3 years later, the curves come together. The logrank test was actually significant. And then one of the very authoritative investigators, like he asked me, is this effect really real? So he wanted to know whether the plateau rates are actually different. And he wanted us to test that. So I feel if you actually do the other way, some reviewers will ask you why you did it this way instead of the tested proportion. So I feel some reviewers, they will focus more on the long-term effects, while other reviewers probably focus more on whether there's any separation anywhere.
Yeah, in our data, it looked like there was good separation in 3 years, but then after about 10 years, another paper was written, and the EFS differences were quite small. Beyond 3 years.
All right, we're actually at the limit here of time, everybody, so If you have any questions, feel free to come up and
Yeah.
ask afterwards. We need to get out of the room because Brian needs to get through.
Right.
Thank you all for coming.
Thank you so much. Happy Halloween.
Great talk.